to the June edition of the Clinical AI Interest Group at the Alan Turing Institute. And what we're going to move immediately onto now is our 3-minute introduction. So this is an opportunity for members of the group to introduce themselves so that we break what is quite a big group down into smaller pieces. And if anyone would like to pop their hand up and just do a free-for-all and just introduce themselves, they are very, very welcome to. If not, I can always, you know, pick someone out. But brilliant. Thank you so much, Vinod.
Hello, everyone. My name is Vinod Kumar Chauhan, and currently I'm a lecturer at the University of Strathclyde. By background, I'm a computer scientist, and over time I have worked in very diverse settings. For example, I did my first postdoc in industrial machine learning at the University of Cambridge, and then I moved on to my second postdoc in AI for healthcare at the University of Oxford. After spending 3.5 years, I have joined my current position at the Strathclyde. So broadly, I'm interested in AI for healthcare, but I'm more specifically interested in causal AI for personalized treatments. My focus is more on developing methodologies because I believe current methods are kind of not ready to meet the needs of personalized treatments, but I'm equally interested in real world clinical use cases. For example, recently I hired a PhD student to work on personalized Alzheimer risk reduction. My main purpose to talk to you through this introduction is I'm looking for clinical partners who are interested in data-driven personalized treatments. There could be many opportunities, I will say, because I'm a computer scientist and we have a complementary skills. It could be from joint publication to funding and maybe joint PhD studentship. So if you are interested in data-driven personalized treatments, then please get in touch. And thank you very much for the organizers for giving me this opportunity.
Fantastic. Thank you so much, Vinod. Round of applause. And do you want to just pop your contact details into the chat as well so that anyone interested in collaborating can get in touch with you nice and easily? Then we have next, so we've got 3 lined up. So we've got Oyen next. Would you like to take it away, Oyen? And I apologize if I've mispronounced.
Thank you. My name's Oyen. I'm the Clinical Safety Officer at HCA Healthcare UK. I'm a nurse by background and I've worked in technology for about 5 years. So I've joined this group routinely to hear about the AI developments in healthcare. But yeah, I'm just really here just to follow along and hear more as we introduce a few AI-based products in the organization. I'm just here to learn.
Thank you so much. Can I ask a really quick follow-up question, which is which AI tools are you currently deploying across your organization?
At the moment, nothing major, but we have a few in the pipeline that we're looking at, but nothing actually in deployment phase. We're taking it slow, let's say that. So yeah.
Brilliant. Thank you so much. Oh, and round of applause. Then we'll have Paul and Neil, and then we will need to draw it to close at that point. Paul,
hi,
the floor is yours.
Thanks so much. So, hi everyone. I'm Paul McInhill. I'm a child and adolescent psychiatry doctor and an AHR academic clinical fellow based at the University of Bristol. I'm currently working up a PhD proposal looking at trying to understand the effect of AI chatbot use on adolescent mental health. Joining this group to learn more about the wider landscape and people interested in the space. And I'm particularly interested in working with AI chatbot developers who would be interested in discussing how we can use some of the findings that come out of this PhD to think about onward development of AI chatbots for use in mental health treatment or identifying demographics of users who would benefit and then help put in safeguards for demographic of users who are at risk of harm from AI chatbot use. Also very interested to have discussions with anyone else working in this space.
Fantastic. And Paul, does the Royal College of Psychiatry have an AI home or an interest group that you can access or network with people through?
Not that I'm aware of. We do have a digital special interest group who actually have done a whole day session recently on AI chatbot use, and I think as a group we are very, very interested in the stories that we're all reading about harm associated with AI chatbots. So there are groups that are thinking about it, but I don't think there's a specific kind of dedicated group at the moment. It's more so a subset.
Brilliant. Thank you so much, Paul. Round of applause. And finally, on to Neil.
Hi, everybody. Neil Graham, a clinical academic and consultant neurologist at Imperial and UCLH. I'm very interested in trying to develop sort of clinical conversational AI using large language models, so sort of turn by turn interactions, and focusing on head injury and cognitive neurology in the first instance. So great to meet everybody, and very, very happy to make connections and collaborate. So excited to hear about what Raj has to say today. So thanks for coming along and convening it all.
Absolutely. And you've got quite an interesting position there, straddling two quite competing organizations in Imperial and University College.
Yeah, perhaps. Hopefully, I think they're both have aligned like vision and objectives to do great stuff, and I think both very forward-looking places clinically. So I think the challenge is to unlock that and help facilitate kind of trials and things. So, but I think at a high level, there's a strong desire to do so.
I only know it from university sports teams, but but I'm glad you're playing an important diplomatic role there. So thank you so much, Neil. Round of applause to Neil. And so that now neatly leads us on to, in fact, it seems like there are lots of different ways that the different people who introduce themselves interests interdigitate with Raj and his specialist area. So it gives me great pleasure to introduce Raj Manrai. Raj is an assistant professor in biomedical informatics at Harvard Medical School. He is also one of the founding leadership members of NEJM AI. And actually be interesting, I know that it's not the subject of your talk today, Raj, but to talk about AI and its use in publishing. But thank you so much for joining us. I also noticed you've got quite diverse interests, and on your bio it talks about your home dance competitions. Now, I'm also quite a keen dancer, so maybe we could save that for the end. But it's a different angle of questioning there to potentially ask Raj about at
This
the end.
is usually losing them to my two young daughters is the critical context that I think you omitted there.
Yeah, absolutely. Anyway, Raj, thank you so much for joining us. We can't wait to hear what you've got to say. And the floor is yours.
Great. So thank you so much for the invitation, and I appreciated that we did the the intros beforehand for a couple of the folks who are in the audience, because I think that was actually very helpful. We don't usually do that in a lot of these types of talks, and so I have a sense, I think, at least a sample of your interests and your backgrounds. And I think there's an interesting mix of, it sounds like already from the folks who introduced themselves, an interesting mix of clinical background as well as computer science. I'm just going to see, actually, if you just give me a moment, I would love to just make sure this looks okay on my side. Okay, great. All right, can you still see this?
Yes, that's all maximized.
Looks
Perfect.
okay? Okay, great. Excellent. All right, so I'm gonna talk today about some of our work on both evaluating and building LLM systems to reason like expert diagnosticians to help in both diagnostic and management reasoning, and also where I think the frontier is, and a few thoughts on where I think the frontier is likely to move in the next year or so. So just as a quick agenda to give you a sense of where we're going, I'll tell you a little bit about my lab and research at Harvard Medical School. I'm going to make the argument. I think there's a lot of clinicians in attendance, so you'll be very familiar with some of the equations that I'll go over, some of the biomarkers that we use in everyday clinical practice, and I'll make the argument that there's a lot of lessons for medical artificial intelligence that we can learn from thinking about and analyzing those very familiar clinical equations, things that we would not consider AI, I think have a lot of lessons for evaluating and understanding AI. And then I'll tell you about my favorite case conference series, the New England Journal of Medicine Clinico-Pathological Conferences, or the CPCs. Of course, this is to talk about AI, and we're talking about what expert diagnosticians and expert diagnostic reasoning looks like. So I'll tell you about our AI system, Dr. Cabot, show it in action, and then give you a sort of a zoom out look at some of the recent progress in AI, and I think where we're headed. As was mentioned, I'm a professor at Harvard Medical School. I'm in the Department of Biomedical Informatics. We have, I think, two recurring themes that are especially pertinent to today's talk, where our lab focuses on understanding and improving, familiar traditional clinical equations, things like the estimated glomerular filtration rate for estimating kidney function, pulmonary function testing measures for understanding how well your lungs are working, ACVD risk scores for predicting who's at risk of a heart attack or a stroke, and so on. And we do a lot of work there that I think is classic kind of clinical epidemiology, but we tend to use a mixture of large-scale available data sets, things like the National Health and Nutrition Examination Survey based in the United States, to other demographic and health surveys from other countries, to the UK Biobank and other resources for analyzing these types of questions. Some of the foundational questions we consider there, like how do we define normal variation? How do we index what's normal for a particular individual to their age, their sex, their gender, their race? What are the assumptions that are embedded in the way that these equations are operationalized? And then what are the clinical implications of changes to these equations, and how can we improve them? And then the other big focus for our lab, and these of course are not divorced from each other, but this is a separate focus, and really the focus of this talk is our work on AI for medicine. And this is very broad. I think see the multiple organ systems here on the traditional clinical equations. Our work in AI in medicine is also quite broad. We do a lot of work with large language models, vision language models, on understanding the frontier of diagnostic and management reasoning in these models, on trying to evaluate and build new systems that are capable of expert reasoning, exploring fine-tuning and alignment, human-machine collaboration, and a few other areas as well. And I put this dotted line here because we like producing PDFs and publishing papers, but our real goal is to have clinical impact. We're a very, very clinically oriented lab. On almost all of our projects, we work very closely with physicians, with other clinicians, and we collaborate with the clinical societies and others to try to really improve and make positive impact on clinical care. Okay, so I'm going to make the argument first before we dive into the AI, that there are lessons for AI from thinking about these very familiar clinical equations. So consider a question that any of the clinicians here probably have to think about or encounter in part of their routine practice. Who's at risk of an MI or a stroke? If you're in the United States, and I think in many parts of the world, you would be very familiar with these 2013 pooled cohort equations, which do exactly this. They predict who's at risk of an MI or stroke. And in 2023, so just a few years ago, they were recalibrated and updated with contemporary data. The question that we asked, so this is an American Heart Association affiliated group, and a very well reputable group that produced this new set of equations that were recalibrated. There's a few other things that happened too. They dropped race as one of the predictors. They incorporated some other variables into the equation. But the question that really I thought we asked that was very important for us was what might change clinically after recalibrating these risk equations. And without going too much into the details, we published this paper in JAMA about in 2024, where we looked at the projected changes to statin and antihypertensive therapy eligibility per guidelines with these new risk equations. And long story short, we found that there would be 14 million plus newly ineligible Americans for statin therapy, and a few million who would be newly ineligible for antihypertensive therapy. And so this is, ostensibly, I think, a good sounding thing, recalibrating the equation with contemporary data, updating the equation. But this was concerning, and I think this is very important to consider in the decision calculus. That update to the equation could have significant impact because it results in a reduction of estimated risk for many Americans in terms of eligibility for very important medications. This has been debated a lot. I think this estimate, a few others were used, and actually the guidelines were recently revised around what the threshold would be to think about initiating preventative therapy. And so that's what you're seeing here. The 2026 guidelines just came out just a couple of months ago. Switching to a different clinical domain, other familiar clinical equations. And this is work that was led by one of my star. He's had many different roles in the lab. He was an undergrad when he first joined my lab, and now he's about to about to enter into his cardiologist training. So he's gone through, undergrad, med school, residency, and now a rising cardiology fellow here in Boston. James Diao is a really brilliant and thoughtful, not only biomedical data scientist, AI scientist, but also a physician. And James led a series of papers where he looked at this very challenging question. And this is a big debate in the U.S., but I think this is a big debate, outside the U.S. as well. Back in 2020 and 2021, around how to index what's normal variation for the estimated glomerular filtration rate, or this common estimate based on creatinine of kidney function. And these were race adjusted previously, and some of the medical centers in the United States, and then this started expanding quite rapidly, started changing the way they were reporting by removing race from these estimates. And James asked the question, what would be the projected impact at a national level? Similar in spirit to the question that you saw that was answered on the previous slide. And there we used a National Health and Nutrition Examination Survey, gold standard epidemiological data to project changes in CKD diagnoses, kidney donation eligibility, drug dosing and contraindications, specialist referral, kidney transplant, and so on. And long story short here, again, this is a race correction factor, race adjustment factor that was in the equation, which seems like a, small multiplier in the equation itself, but with profound potential impact on guideline recommended care for adults across the United States. Similar analysis, but I think much larger in scope, where we looked at not just clinical implications, but financial and occupational implications. James conducted I think a very, very large and very, very impressive amount of work in a New England Journal of Medicine paper that was published in 2024, where we looked at this question, but for lung function equations, pulmonary function testing measures, and the use of spirometers. And again, here, profound changes to what seems like it might not be a particularly, large consideration, right? This is a multiplier in a well understood equation. But when you change how you're indexing normal variation, or you get rid of that term, depending on how you get rid of it, you'll have different scales of changes. But these adjustment terms, or these ways of indexing normal variation, really do have potentially profound clinical and non-clinical consequences. So we made the version of the argument that I'm about to make here, formally in an extended form in this piece in NEJM, where we compared the questions that we asked to understand the values that are embedded in our traditional clinical equations, how they map onto the same types of questions that will help us understand AI models that are in clinical use or are being considered for clinical use. So if you looked at those examples that I just gave you, we were, concerned parts of it. I mean, we were analyzing downstream the clinical impact of changes to those equations. But some of the questions that we were thinking about, and some of the questions that the creators of these equations or the new incarnations were certainly thinking about, pertain to the training data on the top. How representative are the data? What biases are introduced by pre-processing, the way the data are filtered, or we drop or impute certain rows and certain columns of information. And so if you look at traditional clinical equations, those hand-selected features can include blood biomarkers, demographics, clinical variables to predict ASCVD risk, and we can change those, right? We can change which features we use in those equations. We can also change which regions of the world are sampled in defining normal variation or indexing a particular measurement to what's considered normal or abnormal. Now, if we look at AI models, we have similar analogous choices. Which corpora, what languages are those in? Are we using to train large language models? How are we filtering explicit content? How are we removing content? How are we defining content that should not be used in the training procedure for those models? If we look at chest X-ray detectors or AI scanners for chest radiographs, what populations are we using in developing those computer vision models for interpreting those scans? Now, if you go down the y-axis here, you go to model development, right? So once your training data are selected, you still have a lot of choices in how you develop your model, both in traditional clinical equations and in AI models. You just saw a few examples. Are you using race or removing race? Even seemingly decisions like that, where you're talking about a multiplier of 1.15 to 1.2 on an equation, can have really, really profound potential changes in clinical impact. What target variables are you using for your clinical equation? There's a big debate in several of the examples that I gave you around how you define that outcome, how you define that dependent variable that's used in training the predictive model that then is used for determining allocation of things like statin and antihypertensive therapy, or for EGFR eligibility for various drugs and nephrologist referral and so on. Sliding over, staying in model development, analogously to those considerations for traditional clinical equations, we have lots of choices for our AI models. How do we define what we are actually trying to predict? Is diabetic retinopathy a continuous variable, or is it a discretized binary, more than mild versus not more than mild diabetic retinopathy in our computer vision model? For our LLM chatbot, which fine-tuning methods are we using in shaping the behavior and the output of those models? So the companies, several of you will be familiar with this, but this is, I think, an important point to emphasize here. They typically employ these processes in building these models after the sort of expensive computational step with large-scale corpora that are used in pre-training. These fine-tuning methods like supervised fine-tuning or reinforcement learning from human feedback are used to train or change the behavior, sometimes quite profoundly, in these chatbots. And so the companies hire humans to write examples of good or helpful responses, and these really do change and make the models much better. But then they also change the behavior of these models, and they align them with those humans and those instructions that are given to those humans that are selected by the companies that are creating these models. And so the humans, of course, are they're writing examples of desired output. They're also ranking different potential model outputs, and that's used as a signal to fine-tune the behavior of the models. And then if we go down to model use, we ask questions in our traditional clinical equations and our biomarkers, like the prostate-specific antigen, which we've been debating for many years. Where is the cut point between cases and controls, between disease and not disease, between needs another test and does not need another test? What are the costs implicitly? What are we asking there? What are the costs of false positives and false negatives? Sometimes we ask that explicitly in decision analysis. Sometimes we ask that implicitly in thinking about where that threshold should be. And analogously for large language models, how broad should their behavior be in clinical use? This is long after the model, the training data are selected, the model's been developed. How should we steer those LLMs in practical use and everyday use? What should be the bounds of their behavior set by the companies? And then in the clinical domain or clinical setting, how widely should that behavior be changeable for those models? If you use these models, you know that they can take on different roles. They can adopt very different personas. They can take on very, very different behavior, right? This is not a device, not a device the way we think of a medical device. Very, very obviously, this is a quasi-alien intelligence that's steerable and changeable into many, many different roles depending on our desired use case. And this, of course, is what makes these models so incredibly useful, is that they can be many things to many people. But I think this also poses very challenging questions for us in clinical practice, and really tests and I think apply strain to the ways we think about how to ensure that AI systems or how to ensure non-AI systems rather are safe, like our regulatory licensing, our other ways of ensuring that that medicine is practiced safely. So the point here, I think there are many lessons for AI from these traditional clinical equations. The same questions that we ask of our traditional clinical equations, I think are the exact same questions that we should be asking of our AI models. I think that, if you're a clinician, I think this means you have a lot of antibodies built up towards overhype, towards distorted claims in traditional clinical equations and biomarkers. I think those same questions that we ask are often very, very useful for elucidating what values are in these AI models, how they're likely to perform, what are the areas that you need to interrogate to really understand and know the performance better. And then another point that I'll just emphasize here is the behavior and the values of these models are shaped by all three aspects of the creation and use of the model, from the training data to how it's developed to the model use. All right. And then we're going to focus today for the remainder of the talk on really this last part here, model use. I think there's, you can have an entire talk or entire PhD or entire department devoted to any of these three different areas. But we're really going to focus on model use and how these LLM systems can be steered into adopting different roles, including that, I think, of an expert diagnostician. Before I dive into the sort of expert diagnosis part of this talk, also just mention, I think this was mentioned in the bio too, I'm an editor at NEJM AI, which is the AI-focused journal from the publishers of the New England Journal of Medicine. And if you're interested in, content around the sort of clinical relevance of AI, both sort of original articles, trials, data sets, benchmarks, perspectives, I'd encourage you to check out NEJM AI. We're really trying to make it the home of clinical grade evidence for whether AI works in practice, whether it works in the healthcare system, many other related areas. And then we have a podcast, AI Grand Rounds, where we get to talk to a lot of interesting folks, like the teams from Google and Ziad Obermeyer, Mark Cuban, many other interesting folks who are leading efforts in AI and healthcare. And it's a lot of fun, long form. And so our guests tend to share very interesting, I think, stories, maybe 30, 40 minutes through the conversation. Everyone's warmed up and they really take us behind the scenes of some of the big papers and other things that they've done. So I reflect, right? So I think this was mentioned too. I'm a PhD research scientist. I studied physics as an undergrad. I went through computer science, bioinformatics training as a PhD student. I never did an MD, but I'm very clinically oriented. Our lab is, as you can probably tell, we like to publish in the main clinical journals. We work with a lot of clinicians, and we like to influence clinical guidelines, I think, as one of the main ways that we know we're doing something that is impactful within healthcare. And so we're very, very clinically oriented as a primarily PhD and non-clinician lab, although there's several clinicians who are always in the group and very much steering the agenda. And we have a lot of clinical colleagues. And so I reflect on why often, right? Why we get to be, through NEJM and through the lab in such amazing sort of clinically relevant settings. And I really come back to this program that I went through a couple of years ago. So this was actually more than a couple of years ago, maybe at this point. I was a PhD student in this very special training program here in Boston called the HST, or Health Sciences and Technology program. This is a very unusual program. So it's between Harvard and MIT. I think that's sort of the first unusual thing, that two institutions are coming together to run this program. And there's an interesting backstory on this that I don't have time to go into. But essentially, the program is trying to take some of the best aspects of both Harvard Medical School and MIT in creating a very clinically oriented PhD training program. There's also an MD training program and MD PhD program. And so you do this very unusual thing as a PhD student where you take, and I'm showing you those courses on the right side there, you take a very healthy amount of the first 2 years of preclinical training. So pathology, genetics, cardiovascular pathophysiology, anatomy, renal, respiratory, and so on. You take a lot of courses that the med students are taking with the med students. And then most importantly, you spend 2 summers on ICM, or Introduction to Clinical Medicine, Medical Engineering, where you are wearing short white coats. you're rounding with the teams in the hospital, you're taking histories and physicals, you're presenting patients to the teams, and you're really getting embedded into clinical care, and you're understanding, I think, the uncertainties and the challenges that clinicians, the doctors, nurses, healthcare administrators, many others are facing. And I think the way they reason and the way they communicate as well. And so they sort of think of you as like a kind of a poorly performing medical student. Again, you're a PhD student wearing a short white coat with the med students, with the teams, with the residents. But it is an amazing education, and I think it really separates the sort of clinical relevance. And I think beyond the vocabulary, which I think is also very important, and the ability to speak to other physicians, I think it really helps you in thinking through this sort of this way of approaching the world and what clinical practice actually looks like. And so I think it makes you also a little bit less annoying to some of the clinicians, and makes some of those collaborations easier. You're not a PhD scientist who's solving problems that are detached from clinical relevance. So I went through this program, and one of the coolest things that I got to do in this program was learn about these case series and learn from this kind of very classic and well-established method of teaching medical students and residents and so on, of case-based learning. And I got introduced to this series from the New England Journal of Medicine, the case records of the Massachusetts General Hospital, or they're also known as the CPCs, or the Clinical Pathological Conferences. They were started back in 1923. They actually started before that, but they were been published in the New England Journal of Medicine since 1923 as a series by a physician, Dr. Richard Clark Cabot, who was based here in Boston back in the first half of the 20th century. So this is what a case looks like. This is a modern case. It follows this sort of formula, or this template. Starts out with a presentation of case. We find out what's going on with the patient. We learn this is typically written by a physician. Dr. Molly Sands here from medicine tells us that this is a 49-year-old man who was admitted to the hospital because he had hypoglycemia, low blood sugar. He was well until 3 hours before his admission. Then he had altered mental status while he was at work. At a meeting, his colleagues noticed that he wasn't paying attention. Eventually his cell phone starts to ring. He allows it to continue ringing. And then eventually he's found by his colleagues on the conference room floor. His eyes are open, but he's obtunded, making non-purposeful movements. They call emergency medical services. They take a finger stick glucose. It's 39 milligrams per deciliter. It's low. So they administer intravenous dextrose. They take him to the emergency department, and so on. We learn then about what continued to happen at the emergency room, and then also his past medical history, occupational history, initial labs, and so on. So this is sort of our, all starts out with one of these presentations, what's going on and what brings the patient to the hospital or to the doctor today. And then this is my favorite part of the case. The NEJM publishes this very robust differential diagnosis, fully referenced and written by an expert who's typically not involved in the care of this patient. And this is where you really get to sort of sit in the sort of expert's mind along with the expert and understand, how they're reasoning about this case. So much more eloquently, articulately than me, Dr. Amy Ballman says, is a 49-year-old man who presented with recurrent symptomatic hypoglycemia. He reported that he had gained weight recently. He was eating 5 meals a day. He had intermittent morning dizziness that resolved with food, and his medical history included Bell's palsy and hypoglycemia that had not been evaluated previously. Social history was notable for his job as a nurse in a medical facility and his family history of diabetes. Initial labs reveal normal A1C, glycosylated hemoglobin level, and a low glucose. And then we have this sort of historical interlude on Dr. Alan Whipple and Whipple's triad. And then finally, Dr. Bauman writes, in constructing a differential diagnosis to determine the cause of hypoglycemia, there are 3 broad categories to consider: systemic illness, ingestion of drugs or toxins, and endogenous insulin production. And then this is what expert diagnostic reasoning looks like. She goes systematically through each of those different categories. I'm not going to go through all of this text or all of her reasoning, but this is expert reasoning. She matches each of those 3 different categories and the individual conditions within those categories to the patient's presentation, his labs, his symptoms, his past medical history, and she concludes with a top diagnosis and this sort of robust differential diagnosis of possible alternatives, that his age, presentation history, and durations of symptoms are most consistent with a diagnosis of insulinoma. This is a tumor of the pancreas. And then she also recommends, to establish this diagnosis, I would initiate a supervised fasting test to monitor for symptomatic hypoglycemia, and she would measure serum levels of all of these things here: glucose, insulin, C-peptide, proinsulin, and beta hydroxybutyrate. So we get her diagnosis and we get her recommended sort of next step in management, which is the supervised fasting test. But then these cases are special because, where they're not merely multiple choice questions on a licensing exam, or even open-ended sort of responses between the presentation and the differential, which already would have been pretty interesting. We find out what actually happened to the patient, because these cases happen. They're real cases based at MGH that have already occurred. And so we learned that after we see Dr. Bauman's differential diagnosis, that the care team for this patient was also thinking of an insulinoma, and they did indeed perform that test in real life, this supervised fasting test, when they were taking care of the patient, and they measured all those same things that Dr. Bauman had recommended. And this supervised fasting test, once it was concluded, was consistent with this diagnosis of an insulinoma, this tumor of the pancreas that Dr. Bauman also suspected. They don't stop there. What happened next? This then precipitated a imaging study. And so if you squint on the left side there, you can see those two little arrows that are pointing to a mass that was localized on a CT of the abdomen. This then led to endoscopic studies, which sized and localized the mass. And then we learned that it was removed. We looked at a sample, the doctors looked at a sample of it under the microscope, and we get this full pathological discussion. And not only that, we then have the final diagnosis: well-differentiated pancreatic insulin-secreting neuroendocrine tumor, or an insulinoma. Turns out Dr. Bauman was exactly right. This was confirmed now, final pathological diagnosis, an insulinoma. And then we also learned that at 9 months, the patient is doing well. We have a follow-up visit, no new symptoms. He had decreased pancreatic reserve from the surgery, has a strong family history of type 2 diabetes, and an A1C that's in the pre-diabetic range, 5.8%. So we learned that lifestyle changes for the treatment of prediabetes and annual A1C checks are recommended. But otherwise, this patient is doing well. And so, again, this is amazingly educational, right? We had the presentation of case where a lot of things are being presented to us. We had Dr. Bauman reasoning like an expert, the expert that she is, through this particular case, and laying out the different categories of what could be in the differential diagnosis, her most likely top of her differential diagnosis, and then we find out what actually happened to the patient, and the reasoning chain that led to the testing and the sort of final conclusion here for this patient. So these are cases that are being used in medical school. They've been used in medical school and in beyond medical school for over a century to educate physicians. You might be surprised, and these are still read by many doctors, who are well into their practice to learn from other experts. But you might be surprised that these cases have been used to evaluate artificial intelligence systems for many decades as well. There's a seminal paper by Robert Ledley and Lee Lusted that was published in Science in 1959, where they introduced these cases as a gold standard of sorts for when we would know we would have computational systems that can reason like experts, when they're capable of solving these types of cases. Fast forward to the 1980s, and the New England Journal of Medicine published an analysis of Internist 1, rule-based expert system at the time, where they also evaluated this system on these CPCs. 2024, GPT-4 performance was evaluated. Amusingly, this was a paper on NEJM cases that was published in JAMA in 2023, not 2024, where some of my very close colleagues, Zahir Kanji, Byron Crow, and Adam Rodman, analyzed the performance of GPT-4 basically out of the box in final diagnostic accuracy, and whether that differential diagnosis that GPT-4 provided included the final pathological diagnosis. And I think this really surprised a lot of folks, that again, out of the box, the GPT-4 system was getting the preponderance of, or the majority of these cases correct. 5 is the top score here on their scale, rated independently by physicians who then came to concordance. And so I think this was really quite both surprising, exciting, and unnerving for many folks, that these very hard cases the AI system could perform this well just out of the box on final diagnostic accuracy. But what I'll point out is that I think, I showed you the case and I went through it because I really wanted to illustrate the following point. The final diagnosis is really only part of the story. Many of the reasoning skills are missed. If we only look, what Dr. Bauman was doing in reasoning through that differential is totally missed if we're only looking at that final accuracy, the system's accuracy on a final diagnosis. We're not looking at image interpretation. We're not looking at reasoning through the past medical history. We're not looking whether there's coherent reasoning on display to get to that final answer. And there's other concerns too. I think if you're thinking about the evaluation of these systems, you might ask reasonably the question of whether some of these cases are actually in the training data for OpenAI or the other companies that are creating their models. So really, we want more than the final diagnosis. I would argue even for physicians, the final diagnosis, well, my physician colleagues will tell me, final diagnosis is not real. It's only part of the story, but it's, for many of them, it's not even really the main part of the story. The main part of the story is that reasoning process and to understand what expert reasoning looks like. And so these cases are not just written up, they're presented live at Massachusetts General Hospital before they're published by New England Journal of Medicine. And this is the Ether Dome, sort of legendary room at the hospital where a physician in front of their peers, and you can see that a lot of their doctor colleagues here are holding a paper which has the presentation of case. They really have to sort of stick their neck out. This is Dr. Vic Khurana doing this, neurology, who's presenting a differential diagnosis. And they have to really sort of stick their neck out. They could be wrong, right? They have to present their differential diagnosis for what they think is going on in this presentation of case. And then only after they learn about what actually happened to the patient, and only after that does the New England Journal of Medicine publish the written full differential diagnosis. So we've been obsessed with these cases, both sort of evaluating them for understanding AI, inspired by Ledley and Lusted and others. But I think this is morphed now into asking the question of, could we create an AI discussant that's capable not only of, doing well in the sort of final diagnosis, but writing up a fully referenced differential diagnosis that cites guidelines, cites the literature where appropriate, interprets those findings very carefully. And then could we also have it present like the CPC expert does in Massachusetts General Hospital, where it's presenting its reasoning for colleagues to interrogate. And so I mentioned Dr. Richard Cabot is a creator of this series. Fortunately, he has bot in his name. So in homage and honor to Richard Cabot, we created Dr. Cabot in my lab. This is an AI system that provides a differential diagnosis in the style of an expert discussant. It has literature retrieval, can adapt to style from any era of the CPCs that the user chooses, and really is intended to generate one of these expert differential diagnoses, both in written and narrated form for any CPC. I won't go into details too much, but just to give you an overview, this is an agentic system. It's using one of these frontier models under the hood. It's OpenAI's O3 model in a lot of our early testing, but we've moved to other models as well in the past 6 months. And the first thing it does is it creates a machine representation of this case. So you see those numbers, it's like an embedding of this particular presentation of case that's given to the model. And it has also a machine representation of all published CPCs. So it finds similar CPCs, and then it emulates the style of those CPCs with O3's model. This then does this iterative literature search and this agentic loop where it has access to millions of papers, and it cites then its sources, it has to decide when to stop and so on, but then it cites its sources and provides a fully referenced written differential diagnosis. You can also just interact with it in fast mode where it's not doing this sort of iterative search through the literature. And then maybe most excitingly for, I think, our physician colleagues, we built a part of the system to be able to generate videos of narrated slide-based presentations. So it writes Beamer code that can compile into a PowerPoint or a slide presentation. And then it also generates a script that's aligned to that slide-based code. And then these are aligned, and we use a text-to-speech model and then map together to produce a complete video case presentation with a voiceover. So I'll show you an example of that, of course, in response to the same case as Dr. Bauman. But before that, it just as a little bit of a sort of historical interlude, it can emulate the style of a case from, a style of an expert discussant from any era. And so if we started with a modern case of a patient who underwent heart bypass, coronary artery bypass grafting or CABG, then the modern version on the right here of Dr. Cabot would present, I think, a sensible response. But on the left, if we're asking Cabot to take on its 1920s expert discussant persona, it really generates this almost sort of amusing and horrified response, right? Imagine being in the 1920s and hearing about coronary artery bypass grafting as part of the presentation of the patient's case. So much for the trustworthy clinical facts. Intermixed with them are extraordinary reports of barbarous procedures which no prudent physician could countenance. We're told earlier that 13 years earlier, surgeons undertook to sew miscellaneous lengths of artery and vein upon the coronary vessels of the beating heart, an enterprise so ghastly that one must doubt the accuracy or sanity of the narrators, right? So this 1920s doctor has not seen CABG, has not imagined CABG, and this expert discussant would be understandably horrified at what they're hearing as part of a clinical presentation. All right, so I'm going to show you now for that same case, the insulinoma, with where you saw Dr. Bauman's reasoning, and I went through the case. I'm going to show you what Cabot generated for that same case, just given the presentation of case. And I might, just in the interest of time, so we have some time for questions, I might fast forward after a couple minutes into this, just so I can wrap up here. But all right, let's see if the volume works.
Good morning, everyone. Thanks for joining today's case conference. I'm Dr. Cabot, and we've got a really intriguing episode of recurrent hypoglycemia in a middle-aged man. So, let's dive right in and, tease apart the key clinical threads. All right, so starting with the storyline. Our 49-year-old registered nurse is sitting in a morning meeting when colleagues notice he's, just zoning out, fidgeting, not answering his phone. About an hour later, they find him on the floor, eyes open, but clearly not purposeful. Emergency medical services pop a finger stick, 39 milligrams per deciliter, very real hypoglycemia. Dextrose goes in, he wakes up, classic reversal. He describes a dreamlike feeling before the crash and has retrograde amnesia for most of the morning. Now, the longer history is almost more telling. For about 3 years, he's had early morning dizziness that he treats with candy or breakfast, pretty suggestive of fasting episodes. Over the past 3 months, he's actually gained a pant size, which, defensive eating often pushes people toward weight gain. 2 years ago, he had a facial droop episode. Glucose that day was 64 and was labeled Bell's palsy. No meds except vitamins, rare alcohol, and no illicit drug use. Family history of diabetes on insulin is present. Remember, he's not on any of those meds himself. Exam after dextrose is pretty bland. Afebrile, heart rate low 80s, pressure mid-hundreds over 70s, respirations 14. BMI 27. No.
I'm just going to fast forward a little bit. So it goes through the labs, and then it
panel is negative.
goes through some of the other lab findings like Dr. Bauman did.
Putting that together.
And then here we have a summary statement.
49-year-old, documented severe fasting hypoglycemia, recurring for years, with compensatory weight gain and no systemic illness. That's the problem I need to solve. Let's spread out the big differential. First, critical illness and organ failure, sepsis, liver disease, bad kidneys. Second, endocrine shortages, cortisol, growth hormone, thyroid. Third, inborn metabolic errors. Fourth, the IGF-2 secreting tumors. And then we have drugs and alcohol, factitious use of insulin or sulfonylureas, and finally, endogenous hyperinsulinism, insulinoma, nesidioblastosis, or those quirky autoimmune antibody syndromes. So trimming the list, normal vitals and labs knock out critical illness. Normal sodium and blood pressure make adrenal insufficiency improbable. He's 49, too old for silent congenital metabolic diseases. No cachexia or masses, so IGF-2 tumors fade. Now, factitious hypoglycemia is tempting because he's a nurse, but the chronicity, the weight gain, and the nocturnal symptoms aren't what we usually see with surreptitious injections. That leaves endogenous hyperinsulinism. In adults, insulinoma is, by far the commonest culprit. So my working diagnosis is an insulin-secreting pancreatic tumor, an insulinoma. The key clues are recurrent fasting neuroglycopenia, normal A1C, defensive weight gain, and absence of any exogenous agent. Next steps, we need the biochemical slam dunk.
Okay, I'll stop there. So, you can probably gather this, but this is pretty much spot on with what our experts said in response to this case in terms of the differential, and also in the next recommended test and in a lot of the reasoning that was evidenced by Cabot, and it's also in Dr. Bauman's presentation. So we've been showing examples, and I'll tell you if you have questions about this, happy to take them there, about how we built the system and how we engineered it to behave, and some of the both good and also I'd say awkward things that it does. But we've been learning about some of those things too by trying to do public presentations, public demonstrations of this system, and we had one such demonstration here last summer, late last summer. This is the first instance of this. And this was, you can see him on the bottom left there, my PhD student, Thomas Buckley, who really is an engineering genius and really did amazing work in building this system. He and I presented, actually, we introduced Dr. Cabot, who was able to then present a case. We also had a New England Journal of Medicine editor who handles the CPCs. On the top right there, Dr. Dan Restrepo, expert diagnostician, come, and Cabot and Dan presented the same case. Then we had the audience select another case at random. Cabot instantly generated, it takes a couple minutes, but near instantly generated its diagnosis, presented a new case. And then one of our colleagues, Dr. Adam Rodman, on the bottom right there, gave his thoughts about how Cabot did and how the human expert did as well. There was a reporter from the New Yorker came up to Harvard to cover this, and I think he wrote a really thoughtful and very interesting and thought-provoking article that was published last fall. So if you're interested in hearing more about that. And then this is really, I think, to me, the sort of maybe the most science fiction aspect of some of this line of work. The New England Journal of Medicine, we got in contact with the head editor there, and he agreed, and they agreed to publish the first AI diagnosis in the CPC series that was generated by Dr. Cabot. And so we got to, just like we have, this is a case conference, right? So humans are presenting, and you sort of see this kind of like transcript of sorts, like cleaned up kind of transcript of sorts of the conference itself. And we got to introduce Dr. Cabot. And so this is me and Thomas, who's a student, the first author of the Cabot paper. We introduced the system, and then both our human expert, who happens to be, I think we got held to a very high standard, one of the very top diagnosticians in the world, very well reputed for his diagnostic ability. Dr. Gurpreet Dhaliwal presented his differential diagnosis in response to this case. Cabot presented its differential diagnosis in the NEJM article, and then both of them had videos. I think Gurpreet was actually calling in. Dr. Dhaliwal was calling in from UCSF in San Francisco, and Cabot also had its video, and both of these are published in the supplement of this NEJM article. This is one case or two cases. You might be skeptical at this point. Maybe I'm cherry picking. I'm selecting good examples from lots of generations. We've done comparisons now with dozens, hundreds of cases where we've looked. This is one of the examples of it. We looked at physicians trying to guess the source when they're blinded to the source between Cabot and the actual published New England Journal of Medicine human expert generated text. Doctors can't guess reliably what's generating what. And they actually, you can make the argument that they're guessing reliably. They're reliably misclassifying the text. And so they're also saying that Cabot's rating higher, again, blinded to the source in overall quality, diagnostic justification, citation quality, and learner engagement. This is a paper that was published in Science just a few weeks ago, where we've looked at O1 and this new set of newer reasoning models, of course now, but this was one of the earliest, maybe the earliest large reasoning model or a big release of a reasoning model by OpenAI, and just found sort of continued improvement over previous diagnostic systems and other models. Zooming out a little bit, just in the last minute here. AI has been tested. I think we're all sort of saturated, and we're very well aware that AI is very good at standardized testing. And so we almost take these results for granted now. But a few years ago, these were science fiction too. And now, we have 99% or whatever the latest results are of the new models on these licensing exams, to the point that we're now questioning the utility, not only for AI, but I think some folks, because of these results, are questioning the utility of those exams for licensing and understanding whether humans are good practitioners of medicine. AI has been also tested for its empathy. Again, I think this would have been also science fiction, right? That these responses are rated more empathetic. when as rated by other humans, of course, than the actual responses that are generated by physicians. And then this is not just hypothetical cases. AI is being used by patients and their loved ones to end diagnostic odysseys and to deliver real value for themselves or for their loved ones. So this is all to say, and I've been in this field for a long time. I think if you asked me a few years ago, I would have said these types of results, like NEJM publishing an AI diagnosis, patients using these systems to end diagnostic odysseys and so on. I would have said this was science fiction. It really is amazing progress, but I think AI and our evaluations are still quite limited. I didn't talk about hallucinations and confabulations. This is still an issue. Even in 2026, these models I think are getting better, but they're also getting better at more subtly hallucinating or inventing details that are just factually incorrect. And in medicine, that can be very dangerous. What data are the models trained on? Are they representative? I think we have very few studies on how humans and AI will collaborate. From our CDS, clinical decision support literature, we should worry about automation bias, alert fatigue, and so on. How do we keep the human in the loop without causing these same sorts of issues? Most importantly, do we have clinical grade evidence? I think primarily likely in the form of randomized studies in the future. For the efficacy of AI, we have very few, very few studies, particularly for this type of reasoning large language model systems that I'm showing here. Imaging and this is sort of separate area of AI that's been, I think, a little more well-trodden for the past decade or two. Very few studies on how performance is changing over time. And where we started, I think we're only starting to grapple with what values are in these models or embedded in use as we're steering these models into different roles. All right, I will stop there. I know I'm like right at 8. I think we started maybe a couple minutes late, but I'm happy to take time for questions if you'd like to stay over a little bit.
Oh, that is so kind. Right, round of applause. My goodness, we covered a lot during that talk, and it was brilliant. I've obviously heard about Cabot before, but to see it kind of unpacked in that way is fascinating. Whilst others are putting their hands up or forming their questions, there have been a few questions in the chat. Firstly, around access to Cabot, to Dr. Cabot. Is it possible for people to have access, or is that
Yeah,
something that might be in the pipeline?
this might be the no, you can access it today. This is probably the first talk I've given where I think I can point to the new version of there's a new version of our website where you can try Dr. Cabot, you can engage with it. Right now, you can't generate new differentials and new videos with it, but there's a set of CPCs that we preloaded into it that you can interact with and that you can use with Cabot. And so if you go to the website, cpcbench.com, you'll be able to access Cabot.
Amazing.
And we're going to release, we're doing this open. So I think part of our other scientific goal here is that I think it's scientifically important to show how to build these systems and where the gains come from. And so we're gonna very soon, this is probably Thomas is the first author's literally probably working on this right now. So
Okay.
the paper's in review right now, and he's sending to the reviewers and but it'll also be on the website. Essentially, how we did it and the instructions for the all the prompts and everything else that are based into the system and the code that's used in sort of the agentic loop in the literature and so on. So it's totally open. It's totally open. Yeah.
Yeah, well, I mean, and I've always really enjoyed the New England Journal of Medicine CPCs. I mean, they're fascinating reading, and I've always thought that. One of the papers that I remember that looked into performance of large language models or chatbots in performing diagnosis was Amy, the Articulate Medical
Yeah.
Intelligence Explorer from
Yeah.
Google, and I think they had something like 20 clinicians, and they had some clinicians who were on their own. They had some clinicians supplemented with search, some with Amy, and then Amy alone. And one of the
Yeah.
things that's always puzzled me is that Amy alone
Yeah.
outperformed in terms of getting the correct diagnosis within the top 10,
Yeah.
even the clinicians that had Amy as well. And
Yeah.
I've never been able to explain that. Do you know why
Yeah.
that is?
I think this is there's this old I think it was actually seriously called this, but it's almost sounds like sort of a music title for this. There's an old thing that's referenced I don't even know what to call it, but it's called the fundamental theorem of biomedical informatics in some
Okay.
papers. And I think it was great at sort of focusing our attention onto this. But the theorem used to go along the lines of human plus AI is better than human alone or AI alone. And
Yeah.
I think, first of all, we never had any evidence for that theorem. But I
Okay.
think what we're learning about and what we're learning now through some of these studies like AMI and like some of the others, and there's some of my colleagues have also done similar studies, but with not AMI, but with some of the like the OpenAI models and others. I think what we're learning is that it need not be the case that humans and AI together function better than humans or AI alone. And I don't think that should, I mean, I think that sounds scary, but I think you should think about how constrained and how artificial some of these exercises are. And I think what's likely to happen is that I think there are likely to be areas where the AI system does very well on its own, and that both doctors and patients are comfortable with AI handling parts of the workflow that used to be handled by humans alone or autonomously. And I think there are going to be other parts where patients and doctors have no desire, neither of them has any desire for AI to even be a part of the process. And I think we're going to start to learn. We have very little data. I mean, this is a great area for people to work on. I think we have very little, I think, systematic inquiry into that about sort of the parts of the workflow that are best served by potentially this collaboration between human and AI or one alone. And I should say also, though I said it just there, but I think a lot of this will end up being some type of collaboration or dance between humans and AI who are working together.
Yeah. And the actual setup, I've never seen that room. What was it called? The room where the cases are presented.
Yeah, the ether. Well, so it used to be in the Ether Dome, which is the like the classic like that was the one. And actually, sometimes even the current cases are presented in the Ether Dome, which is the room that I showed there, like the
Yeah,
amphitheater at MGH.
exactly.
But I think now they're like they typically happen. I've gone to a couple other ones like at a more boring conference room,
Okay.
but unfortunately, there's like I thought that one was pretty cool because of the
That is
historical
very cool.
significance of the room. Yeah.
Olga, would you like to ask a question?
Yeah, thank you. Hi, it's Olga Kostopoulou from Imperial College London. Really enjoyed your talk. Um, how does it do on simple cases? Because I'm thinking it's trained on really difficult cases. So when you give it a simple case, how does it perform? And if it does try to sort of go over all the possible differential diagnosis, does it end
Yeah.
up suggest lots of tests?
Yeah, yeah, yeah.
No,
Totally. Yeah, so you're actually asking several, I think, very important questions. These models can be aligned to be completionists, I guess is what we would say. Maybe that's a bit charitable, but essentially, like they're usually educational, right? Like they're teaching you about all the possible options just almost by their nature, the frontier models, and giving you lots of like a menu of options, and then trying to sort of take your feedback to then hone in on what you're interested in. And so that's not necessarily what you want your doctor to do, right? And which is to just always be giving you a menu of options. But I think for your large language model, I think it's an understandable setting for the default settings out of the factory, but it needs to be tuned for actual clinical use. And so the short answer is, I think the version that you saw was very much intended for full CPC discussant, but that's not what you wouldn't want that in practice for your simple case or just sort of iteratively responding to it. But if we have a simple case, so we just there's I think I mentioned that I showed like a slide of this. You can engage with this without doing the sort of full literature search, without generating the full differential diagnosis or the videos, and just kind of have a conversation with it like you would have with your standard chatbot or with your physician. And so again, I think someone else is also asking about this, so it's worth saying this. This is a research and educational project right now. It's not a clinical tool, although I think what's been quite astounding is that after like the New Yorker thing came out, again, it was like a public demonstration amongst like physician colleagues, right? After that came out, a lot of patients have reached out to us and asked like, can we access this thing? Can we access this for my mom and so on? And I have to say that like it's a research and educational tool, right? Like we're not intending this to be like a medical tool. It's not that. It hasn't gone through any of that process, but it's intended to show that we can we can essentially how we can approach this sort of expert level discussant through these models and through the tooling that we build around it. But the short answer, so sorry, just the short answer to your question, I think another point to emphasize here, we tune it for the specific use cases. We're currently doing studies now where we're trying to analyze this and more operationalize this more real clinical workflows with our colleagues at the hospitals. And there we're sort of first doing retrospective studies. And we're tuning into the specific cases, second opinions in emergency department, internal medicine settings, and so on. And they're tuned to what the physicians there would like to see in terms of the response.
And just to follow up, what about uncertainty? Because I noticed that you present the features that support the diagnosis, but not sort of the missing features or the features that pose the diagnosis, which is very important for educational purposes.
Totally. So I did, I think, not to over defend Cabot, but I think I fast forwarded through some of that. It was actually in that video, but there's some of that both in the differential part, but especially in the part after the differential, like that I just skipped because we were low on time. There's I think Cabot typically has a slide that it calls teaching points. And because these cases are didactic and it's emulating the expert, we program this behavior into the system so that it tries to be kind of didactic and have some of these teaching points, which includes a mix of the both positive but also sort of the missing findings that you're talking about. But I think that's a great area that we can go deeper into that we haven't really systematically studied this yet.
Thank you.
Yeah.
Thank you so much, Roger. We are going to have to come into land there. So thank you. Sorry not to get to other people's questions. One really quick question, which is obviously, if it was to be used in clinical practice, it would be classed as a medical device. But you've already answered that we're not going, that isn't in the immediate pipeline for usage. It's a research tool at the moment. Is that correct?
That's correct. Yeah, it's research and education. Yeah.
Brilliant. Thank you so much, Raj, for joining us.
Yeah, and if folks have questions offline, you can share my email. I'm happy to talk offline.
That's really kind, really kind. Thank you so much. Brilliant. We're going to come into land there. Our next meeting will be on the 14th of July when we're going to be joined by Federico Nanni from the Alan Turing Institute, and he's going to be talking to us about small language models and their use in clinical applications. So Raj, maybe come back to join us there if it's not too early in the day.
Awesome. Yeah, thanks. This was great. Thanks for the invitation.
Brilliant. Thank you so much again to Raj. Thank you so much again to our 3-minute introductions, and look forward to seeing you all very soon.
All right.
Bye-bye.
Take care, everyone.